what's really happening with the metabolic changes that, where we start gaining weight, our bodies start to shift, the things that we used to do to maintain our weight, or, we're exercising all the time. We're doing all these things that are good for us, and everything's just changing. And it's very frustrating for so many women because, again, this is a big shift. And there's so many changes that are happening, not only in your body, but in your life many times. And it can be very distressing for so many people because you add that on to everything else that's going on, whether it is that you're becoming an empty nester, or now you're caregiving, or you're changing your career, whatever it is, it can be really stressful. So, what's going on metabolically during this time that makes weight gain so common?
So I think what happens is, with women, this whole estrogen component, right? When
Right.
you don't have enough of it and it's fluctuating, and, some days it's more and other days it's less, it causes an inflammatory reaction internally. So there's really, and that's why cortisol is trying to calm your system down. All of these things are really, we're trying to get to the root cause of what's going on, and
Mhm.
we're trying to calm down that inflammation. So the lack of estrogen, or the declining estrogen, causes inflammatory responses all throughout our bodies at a cellular level. And then that leads to a pseudo insulin resistance component, per se, right?
Right.
And again, now, your body is producing that insulin. It's just your cells aren't recognizing it. So the
Mhm.
foods that you eat, things that you normally eat, in the bloodstream, instead of being used to provide energy, are being stored as fat inside around your organs. So that's why it's called visceral fat versus subcutaneous, because it's more dangerous, basically. So
Mhm.
imagine your liver and your gallbladder and your stomach and everything just kind of wrapped in little, fat molecules. That's what's
Right.
going on internally. And that's all based on this, imbalance going
Mhm.
on internally, and all due to inflammation from lack of estrogen. So I
Mhm.
always tell patients, it is not a one-sided equation when we're treating all of these
Right.
perimenopausal symptoms. So
Mhm.
hormones aren't going to be the end all be all. You cannot, people think, so if I go on hormones, am I going to lose weight? No, it doesn't work that way.
Right.
We're just balancing your hormones out with the hormone side of it.
Mhm.
Sometimes when you do that, then that internal inflammation kind of calms down and your system starts to rework again.
Mhm.
Other times it doesn't. And so you
Mhm.
have to use other methodology to kind of, get into that next phase, kind of reset your system and then move forward.
Mhm.
Okay.
Mhm.
So this weight gain is different than what we had when, when you would go on vacation, gain 5, 10 pounds,
Right.
come home,
Right.
monitor what you were eating, do a little extra cardio, and you'd lose it. It doesn't work like that. And
Mhm.
that's the problem women are having with this weight component of it, is they're banging their head against the wall. They're like, okay, I'm just going to, starve myself, basically. I'm on a
Right.
500-calorie diet and I'm going to
Right.
go crazy with the cardio. All
Mhm.
that's doing is raising those inflammatory markers.
Exactly.
And guess
It's
what? The
stress.
weight keeps going up and up and up. And they're like, I don't know what else to do. And they're frustrated. Like, they
Right.
are beside themselves, because women, at the end of the day, it's all about how we look and how we feel. And
Right.
that all plays into it. When you feel fluffy and your clothes don't fit right, and you look at yourself and you don't look like yourself, like, they
Right.
look puffy, they looked inflamed.
Claimed. Yeah, exactly. So what's the, sort of the way to handle this? Like, what do you suggest to your patients?
I like starting everything from the base up, right? Like,
Mhm.
it's all about nutritional components. It's all about
Sure.
exercise regimen, and that has to be tweaked completely, because I have to tell you, 9 out of 10 women don't have it right. And it's
Mhm.
not their fault. We weren't really taught all of it. Again, here I am, a gynecologist. I'm a nutritionist and exercise physiologist now, right?
Right.
You need to pick this stuff up. That's why I always say, this is not just, I have to be holistic. I have to look at the whole overall woman, or else I'm not doing them any service. You
Right.
can't just hand out hormones and be like,
Right.
be on your way.
Mhm.
I fixed something, but I didn't fix the whole overall problem. Like, we still have
Mm.
more work to do. So we need to really delve into that. And honestly, a lot of diet modifications will
Mhm.
help with that inflammation. There are
Mhm.
certain foods,
Sure.
that if you add, will help bring everything down, and
Mhm.
you feel fuller, you feel better. And it's kind of like, oh, wait, I didn't realize I could do that with food because again, the gut microbiome is offset too. So you have to
Right.
fix that. And then the exercise component of it, it's a again, it's a crapshoot for everybody. You need some cardio, but you need weights, you need resistance, you need muscle building activities. Otherwise, we're gonna have muscle loss and then
Right.
you're gonna have bone loss
All
on
lost.
top of it.
Yep.
So,
Mhm.
and then you need the protein and you need the this. And so it's like, there's always this thing on social media where you see it's like it's a full-time job to
Yeah.
keep up in midlife. Like, did I eat my protein? Did I get all my supplements? And did I get
Right.
all my water and creatine? And that again, there is a reason, there's a method to the madness basically. And we
Right.
need to make sure women understand that and kind of,
Um,
chip away at it. Is it gonna be overnight? No, but it's a steady climb, but you will get to the other side of it.
mhm. Yeah. Um, I wanna ask, I wasn't planning on asking, I'm just gonna ask, what's your opinion of these GLP-1 agonists? Like, how does that fit in for your patients that are like this?
So again, that's another part of like obesity medicine now, right? That I have to
Right.
delve into, and I'm like, okay, I guess I'm
Exactly.
gonna get that certification. It keeps like we're always learning, and I think if you find a
Sure.
practitioner who's always learning and evolving, you're good. If the ones that are like, no,
Mhm.
I'm done learning, yeah, you know
Sure.
what, we're done with
Yeah,
that too. We need to
exactly.
move on.
Mhm.
I'm always going to be an eternal student, because there's
Mhm.
always something else coming up. So there is a place for them. I have to
Right.
say, there is a
Mhm.
place for them if
Sure.
done appropriately, correctly. The most recent study that was just published was on that and HRT. So they took
Um,
women who were in midlife who needed to lose weight with hormones and GLP-1s and with only GLP-1s. And the women on HRT plus GLP-1s lost 30% more. So
yep.
the proof is in the research.
Yeah,
And
exactly.
again, what I explain to patients is this is not a band-aid situation. This is like, well, what if I come off it and I bounce back? I said, this is not that situation. Okay.
Right.
This is a different methodology to it. There's a reason for this insulin resistance. We know what it is, and we know how your body is going to be metabolizing this peptide, basically. You're just
Right.
giving it a boost to kind of fix, that internal switch and make it
Mhm.
work.
Mhm.
And so later, once, and again, the weight gain that we're talking about is a good somewhere between 5 to 15 pounds per
Mhm.
woman. Okay. And it creeps on up on them within like a year or two. So
Mhm.
we're not talking the women who need to lose extra amounts of weight. That's
Sure.
not the situation. This is like the 10 to 15 pounds that they gain in this midlife shift. And once they get, they're able to get back down to where they need to be, they can, again, I've spoken to endocrinologists and they're like, well, it's kind of like any other medication. If you feel good on it, why would you come off of it? Okay. Or
Mhm.
they're like, then you just kind of wean off. Now you've reset your system.
Exactly.
And you know what? You're not going to need it anymore and you're not going to gain the weight back.
Mhm.
And
Right.
that's what I have seen in
Mhm.
practice. So everything, that we do is research back, number one. And number two, I see it
Absolutely.
on a daily basis. And,
Right.
they're like, oh, but somebody got pancreatitis and the other one got this. And yeah, again, everything can be abused. And if
Right.
you abuse it and you're not going to the right place and you're getting it at a med spa, then I'm sorry. I don't
Yes.
know what they gave you.
Right.
Okay.
Exactly. Exactly. I think that's a really important point is you have to go to somebody who's really trained and understands how everything interacts, but also, what to look for, how long to be on it, and how to tweak your dose of both your hormones and, a GLP-1 agonist. So there's a lot of complexity and you can't just go anywhere for that. So I agree. So, I want to talk about, um, sort of this midlife sort of wake up call that happens for so many of us in our 40s and 50s. I'm in my 50s, right? And we start thinking about our next phase of life, right? And longevity. I just wrote a book on longevity. How does menopause affect our longevity as women? What are some of the things that we really need to be thinking about as we move into that phase of life?
It's interesting that this, I think I read somewhere, longevity is a term of 2025.
Mhm.
And I can understand why, because we're all talking about it,
Right.
longevity, age management, whatever name you want to give it.
Sure.
And it is so fun to kind of be in this realm right now
Yeah,
because,
totally.
again, always I have considered myself an obstetrician and women's primary healthcare provider.
Mhm.
I gynecologist. Because why? Women are typically healthy. Pregnant women are pretty much healthy. We don't have a
Right.
lot of issues going on.
Mhm.
And in midlife, they're still healthy. It's not until after this menopause, this
Exactly.
estrogen drop that kind of things go
Mhm.
haywire with us.
Right.
And so if I can avoid that, then technically we're helping their longevity going forward. So
Mhm.
how do you do that? It's the heart disease, it's the osteoporosis, and it's the dementia components. Like, you need to be able to minimize all of those risks well before they're even kind of coming up or creeping up on them. And if you can
Right.
do that, we're building in their longevity now.
Mhm.
And
Mhm.
it's, how do you want to be in that nursing home? What kind of shape do you want to be in? And what kind of quality of life do you want to have is really what's at the root of what we're doing with hormones and GLP-1s and whatever else have you. Because everything we do is about minimizing your risk for developing diabetes, which then we know can cause heart disease, which then
Mhm.
can lead to heart attacks and things like that. So the goal is to improve longevity by just being preventative. We want to be preventative, not reactive. We don't want you to get
Uh,
sick and then be like, now you need a blood pressure medication and you need a cholesterol medication and you need this
Right.
and that. We're trying to avoid all of that. And if you
Mhm.
can catch them in their 40s and kind of guide them gently, because guess what? Every single 40-year-old I see when they do their labs, their LDL's already popping up. Do I need a statin? No, you don't need a statin. You need to calm down. We're going to manage your diet. And then we're going to maybe add a little hormone. And then I'm going to recheck it in 6 to 8 months and see where we're at. Because guess what? Most of the time it comes down, because that is, again, another hallmark of perimenopause is
Mhm.
LDL. All of a sudden, you never had a cholesterol problem, and now you do.
Right.
So that's the goal of where we go with longevity is honestly prevention of
Mhm.
disease, not rather than treatment.